Okay, hi everyone. This is our lecture on chapter 6, which is risks related to substance use disorders. So hopefully, oh, there we go. Sorry. So it is a rather long chapter. I guess I forgot how long it is. But anyway, I may break it up into two parts. Okay. So first learning outcome is just to identify common substances of abuse and just sort of related general pathophysiological concepts, right? So the same kind of figure that we see really at the beginning of every chapter. So in terms of the most common substance use disorders, alcohol, tobacco, cannabis, stimulus, hallucinogen, and opioid, we're going to talk a little bit about each one of these in this chapter. If you think about what a psychoactive drug is, right, it's any drug that's going to affect emotion, mind, or behavior, and obviously has other effects as well. And these psychoactive drugs really do impose a substantial health burden on society. I'm sure if you just think about the opioid crisis and what burden that has posed on society. But obviously, any of these, other big ones too, alcohol and tobacco use as well. Okay, so if we look at some of these concepts that are related to substance abuse, okay, there are many. Again, if we're talking about, psychoactive drugs, they're obviously going to exhibit actions in the brain. A lot of them also have peripheral actions as well, and we'll talk about that. Okay, so if we kind of take a look here, we start off, obviously the if we're going to talk about a substance use disorder, that's suggesting that the patient is addicted, right? So addiction is the main issue here. However, addiction and what obviously if we're talking about addiction, that means there's repeated use of some specific substance, right? One of the ones we listed. And so depending on what substance we're talking about, it's going to have other effects, right? And can have effects on oxygenation, on nutrition and digestion. And then you can kind of look further out here in terms of some specifics, right? So if we look at things connected to nutrition and digestion, right? Loss of appetite, maybe nausea and vomiting. It could be this is again sort of chronic use once you're addicted to that substance. Okay, we can see effects on perfusion, right? So things like stroke, changes in heart rate, right? Tachycardia, hypertension, heart failure, all of these can happen as a result of repeated use of these substances, okay? If you look over here at mood and affect, obviously if we're talking about psychoactive drugs, you're going to have effects like that, right? Paranoia, confusion, anxiety, a laundry list here, and you can list others as well, okay? If you look at even other neurologic effects, seizures, right? Balance issues, those are some other issues there. Okay, so hopefully we kind of understand the sort of broad implications of, substance use and abuse. All right, so next learning outcome is to describe the neurobiology of the brain, right, and how it relates to substance use disorders in general. Okay, so this first part is these are concepts that are going to be applied to all of these different substance use disorders that we're going to talk about. Okay, all right, so first, just a little bit of anatomy and physiology of the brain. And again, this is not, an in-depth sort of analysis of the brain structures that are involved. It's much more complex than this, but we want to understand at least some of the main brain regions that are going to be affected when we're talking about substance use, okay? So brainstem, if we think about the brainstem in general, the brainstem is involved in controlling basic functions, right? Like heart rate and breathing, okay? Cerebellum is involved in motor control. So as you saw in that concepts figure, there can be changes in sort of motor control, right? And balance and things like that. Why? Because these substances can affect the cerebellum, okay? Again, if we're talking about, brainstem, we talked about changes in heart rate, changes in respiratory rate. Why? Because these drugs, these substances are going to affect areas of the brainstem that are involved in those functions, okay? If we now go down here to limbic system, okay? We talked or mentioned limbic system before when we were talking about stress. Let's think about so hippocampus and amygdala are part of the limbic system, right? So when we think about hippocampus, we want to think about memory, right? So storage and retrieval of memory. The amygdala is kind of where the emotion is going to kind of come in. So sensory information, emotions, the one particular emotion you probably usually associate with the amygdala is fear, okay? And you can see how sort of the hippocampus and the amygdala will work together in sort of, tying emotion to memories and things like that, okay? We're also going to consider the reward center sort of part of the limbic system as well, okay? So when we're talking about anything that's going to be rewarding or initiate feelings of pleasure, right? It's that center that's going to be activated. And we're going to talk a little bit more about that. And again, we did mention this. We actually mentioned the reward center a little bit when we were talking about leptin, when we were talking about that in the obesity chapter. Okay, a little bit more, some other kind of, just if you want to kind of call the region of the brain where the hypothalamus and the thalamus are, the diencephalon. I don't know that you need to know the term diencephalon. I just want you to know hypothalamus and thalamus. We talked about the hypothalamus a lot in our stress chapter. We were talking about it again in the obesity chapter, and now we're mentioning it here. Why? Because the hypothalamus is involved in regulating the autonomic nervous system, right? Also regulating the endocrine system. And also just basic drives like appetite and things like that we talked about in the obesity chapter. Okay, so the hypothalamus is going to be affected by these substances that we're talking about in this chapter. Thalamus is really going to be, we kind of think of that sometimes as sort of a relay station. So any sort of sensory information that's coming into the brain is going to go to that thalamus first, and then that's information is then going to be sent off to other brain areas. So it's essentially going to have effects on, again, sensory perception and movement if something's going to interact with the thalamus. If we then think about the cortex, right, the cerebral cortex, there are sensory association areas there, right, your sensory cortex, primary sensory cortex is there, primary motor cortex, also sensory and motor association areas. So again, thinking about some sensory information, even just like the feeling of something, or if something feels hot, it comes into the brain, right? Ultimately, it's going to go to the sensory cortex, okay? And then sort of get processed from there. Same thing if we're thinking about initiating motor, right? Initiating movement, it's going to start in that motor cortex, okay? And then there are other parts of the cortex that are going to be affected as well. So it's just, these are just listing the different lobes of the cortex. So if we look at a picture, right, we can see I think most of these brain regions that we mentioned. Okay. Now, I'm not going to ask you on the exam to identify brain regions. I mean, I'm sure we have heard of some of these brain regions even in anatomy and physiology, right? And you had to probably identify some of these there. But just to kind of have an idea of where things are located. Okay, so we mentioned the cerebellum. Well, if we can see here, right, this is the hippocampus here, okay, and the amygdala, they're very closely associated. This is the cortex, right? So when we're talking about the cortex, that's what we mean. This sort of sits on top of some of these other subcortical structures that I was just mentioning. Okay, we will talk a little bit more about the basal ganglia next. Okay. So again, now that was just kind of basic anatomy, right? Some brain regions that are going to be affected by these substances. Now I guess this just gets a little bit more specific, right? So again, when we talk about how the brain functions, right? Neurons are going to talk to each other or send information by the use of synapses, right? So you can think of a synapse as sort of, the connection between two neurons, okay? Now, there are electrical synapses, but not that many. So really, we're going to focus on chemical synapses. So what do we mean when something is a chemical synapse? We mean that one neuron is going to release a neurotransmitter, right, into the synaptic space. That neurotransmitter is then going to bind to the other cell, the postsynaptic cell, and initiate some sort of effect in that neuron, okay? And so we have listed here some examples of neurotransmitters, and we're going to talk about some of these as we move through the chapter, okay? It says here that they can reinforce the effects of drugs. Most of these, actually probably all of these substances that we're going to talk about in this chapter in some way affect one of these neurotransmitters, okay? So big one, dopamine, we'll talk about that. Opioid peptides, we're going to talk about, opioid use disorder. but there are endogenous opioid peptides that also act as neurotransmitters. We'll talk about GABA. I think I mentioned glutamate, maybe not so much, but anyway, GABA is mostly inhibitory, whereas glutamate is going to be the neurotransmitter that we think of as being excitatory. Okay, serotonin and acetylcholine. We're going to mention all of these neurotransmitters again because these substances or these drugs of abuse or these psychoactive drugs will ultimately affect neurotransmitters in some way, whether it's the receptor of the neurotransmitter, right? Whether it's release of the neurotransmitter, but in some way, neurotransmitter levels are going to be affected or neurotransmitter action is going to be affected, okay? So I said we're going to talk a little bit more, about this reward pathway, okay? And I'll show you a picture in a second. So one area of the brain called the VTA, okay, is important in sort of kind of the first, I guess, part of some of a dopaminergic reward pathway or the reward pathway. So we're just going to start there at the VTA, okay? The VTA connects to the basal ganglia within that limbic system. So remember I said we're going to talk about the basal ganglia a little bit more. The basal ganglia function in regulating emotions and motivation. So really kind of any part of this reward system is going to be involved in emotion, involved in motivation, okay? What happens if a drug is going to activate the VTA, right? And really any drug or any substance that's going to have rewarding effects is essentially going to activate the VTA, right? And so ultimately there's something that's going to activate those neurons, right? To basically release dopamine, okay? And so what happens is those, and I'll show you a picture in a second, but those neurons in the VTA, they're the ones that are going to produce dopamine, right? Which is a neurotransmitter, but they're going to project to the nucleus accumbens. And so what you see is an increase in dopamine in the nucleus accumbens because that's where it's released, okay? So again, we call this a reward pathway. And so what we were just focusing on, right, was this right here, okay? This mesolimbic pathway, okay? Now, by the way, this is giving you an example of 3 different dopaminergic reward pathways. I really only just went through in detail this mesolimbic pathway, okay? So again, here's your VTA. So the substances that we're going to talk about or any other sort of substances that are going to lead to sort of reward or going to elicit some form of pleasure or something like that, this VTA will be activated, this area of the brain, right? These neurons that are here will produce dopamine, right? And then their axons will project into the nucleus accumbens. So what you see an increase in dopamine in the nucleus accumbens because these neurons have become activated. Okay, so again, this is one of the major reward pathways in the brain. These other pathways, the mesocortic pathway and the nigrostriatal pathway, these are also reward pathways that, again, it's dopamine, okay? When you think about here, substantia nigra going to the striatum, the dopaminergic neurons in this area, in the substantia nigra, actually become degenerated in Parkinson's disease. Okay, so this pathway is also involved in sort of motor control as well, but also involved in emotion and motivation as well, right? So all of these pathways, again, these reward pathways are involved in emotion, motivation, sort of the feelings of pleasure, where you're going to get sort of these reinforcers, right? You're going to take a drug, it's going to make you feel good, therefore you're going to want to do it again. Okay, so again, these are all dopaminergic reward pathways. The one we focused mostly on was this VTA to nucleus accumbens, right? And that's the mesolimbic pathway. Okay, so if you want to know a little bit more about these 2 pathways, you can look it up, but essentially you can see what's going on here, right? It's the same idea. These are all dopaminergic neurons. So for the mesolimbic pathway, right, the dopamine is going to be released in the nucleus accumbens. And that's really gonna, you hear people say kind of if there's an increase in dopamine in the nucleus accumbens, that means that indicates addiction, right? Or that substance has the potential to be addictive. And so that's really where the reinforcement comes in, okay? When we talk about this pathway, this red one here, right, the mesocortic pathway, again, it's dopamine that's going to end up being increased in these cortical areas. And so it's mentioning here the prefrontal cortex, and this is going to affect decision making, right? So that's the area of the brain that's involved in decision making. So obviously that's involved in whether you're going to take a drug or not, and how often, and what have you. And so that's where we're going to, I guess that's a sort of maybe something that's specific to that pathway. Okay. But again, all of these are involved in reward. Okay. So let's move on a little bit more, again, to kind of talk about some terminology. So we just said there's increased levels of dopamine, right? So in general, in any drug of abuse, any of these substances that we're talking about, you're going to have increased levels of dopamine, okay? What that leads to, right? Feelings of well-being, exhilaration, pleasure. I mentioned this, okay? But then, there's sort of some other things that start to happen, right, over time as that substance is used repeatedly, okay? So one thing that can happen, or one thing that occurs is, oh, by the way, too, just a reminder that to check the notes, okay? There are some notes in some of the slides. I think I did this last time. And also, good idea to have your review sheet in front of you. I may have to, or we may together kind of slightly modify that review sheet, because I think I did add in a little more detail since I wrote that review sheet. So make sure you're really taking a lot of detailed notes. Okay, so that was just kind of a little side note there. All right, so when we talk about psychologic dependence, right, it says here a state of uneasiness when the drug is not available, right? So this is the idea that you feel like you need that drug, okay? When we then move to physical dependence, the drug is actually needed for everyday function, right? You can't go to work without taking that drug, okay? Tolerance, that idea or the concept of tolerance is that more drug is needed to achieve that desired effect, okay? So instead of having one drink, you need to have two, and then over time, maybe you need to have 5 drinks before you feel like you can function, right? And this partly is due to the fact that if you have some substance around sort of all the time, right? Higher levels, say, of alcohol around all the time, your body compensates for this by reducing the number of receptors, okay, that are going to essentially, that substance is going to bind to. And so what happens then is you need more of that substance to initiate the same effect, because there are less receptors, right? Or there could be less of the actual neurotransmitter that's involved as well. Okay, so it's an idea that it's your body's sort of compensation for the increased levels of some substance around, but that ultimately leads the patient to take more and more of that drug. Okay, and so if a drug, if you see tolerance pretty quickly in a certain class of drugs, or you see that it, that's, so I guess you could say quickly, I would think you can think of kind of these drugs as being more dangerous, right? In fact, in terms of overdose. Okay, withdrawal, right? Symptoms occur when the drug is abruptly stopped, okay? And so this is sort of the defining characteristic of physical dependence. And there are certain, symptoms that you'll see with withdrawal, and we'll talk about that. Or I'll mention that. And yeah, I'll kind of mention that specifically when we talk about some of the different substance use disorders. So there's no need to kind of go through that right now. There are other, so we kind of just been talking about dopamine predominantly, right? I showed you those reward pathways that are, the dopaminergic pathways. But other neurotransmitters will modulate dopamine, okay? So other neurotransmitters like serotonin and GABA, those two in particular are involved in modulating the release or the production of dopamine, okay? So serotonin says regulates the release of dopamine in the VTA, right? So meaning if serotonin levels are impacted in some way, that ultimately will impact dopamine levels as well. GABA is, again, mostly an inhibitory neurotransmitter. It will inhibit dopamine release from dopaminergic neurons. Sorry to be redundant, right? When we say dopaminergic neuron, we're referring to a neuron that produces and releases dopamine. So GABA can inhibit those, okay? So inhibits dopamine release. Drugs like alcohol, barbiturates, benzodiazepines, they'll all interact with the GABA receptor, GABA A receptor in particular, for benzodiazepines. Okay, so just to kind of think about, there are drugs that will interact with GABA, right? And again, though, ultimately can affect dopamine too. Okay, just not directly. Okay, so now we're going to specifically talk about alcohol use disorder first. Okay, so causes, classification, underlying pathogenesis, and clinical manifestations. Okay, and also some treatment strategies. So first one. So again, you can see why this chapter is long, because we have a laundry list of substance use disorders to kind of go through. Okay, all right, so just an overview first. So it says that alcohol use disorder is the leading cause of preventable death. Okay, risk factors, genetics, right? Psychological factors, and also other environmental factors come into play. I mean, often you do, see alcoholism in families, right? There is a genetic component. In terms of psychologic, if you have psychological issues or a psychological disorder, sometimes that then puts you at increased risk for alcoholism. Other environmental factors in terms of culture and things like that can influence it as well. Now, this mentions here DSM-5 categories. Okay, so in terms of like, how do you set up different criteria for whether it's mild alcohol use disorder, moderate, or severe? Okay, and it has to do with the number of symptoms that patient has as outlined in that DSM-5. Okay, so let me just show you what I'm referring to. And again, any time that DSM-5 is mentioned, you can kind of go back and maybe take a look at that more. But basically, this is for, let me just pull this up and I'll just show you. So, I mean, I just wanted to kind of make sure we understand what we're talking about when we mention DSM-5. So this here, so this is pulled from NIH, right? So National Institute on Alcohol Abuse and Alcoholism, which is part of the NIH. This is actually showing you the difference between some of the diagnostic criteria between DSM-4 and DSM-5. Remember that DSM stands for Diagnostic and Statistical Manual of Mental Disorders. Okay, so 5 is just a newer version of 4, and usually they refine some of the criteria in terms of diagnosis. So any mental disorder will be in this DSM. Okay, and so we were just talking about in terms of kind of the different symptoms, right? And so when you say you have two or three of them, it's from this list. So in the DSM-5, for any, mental disorder, there will be a list of symptoms, right? Or a list of criteria to help in the diagnosis. And so often it's categorized based on number of symptoms within that list. Okay. So I just wanted to kind of point that out. And again, it's something that you can kind of look up on your own. We're not going to memorize anything like this, but I mean, this is something that perhaps I could put on the exam and say, here's the DSM-5 criteria. Here's the symptoms that your patient has. Tell me if, what it is. Is it mild, right? Is it, we were back here. Sorry. What the heck happened? Right? Is it mild? Is it moderate? Or is it severe? Okay. One other, maybe that's next. Yeah. So, and then I'm going to show you something else. I also have the e-text of the book, that I'll pull up at certain points too, just to refer to a couple tables that aren't actually in the PowerPoint slides, but I think they're sort of worth looking at. Not something, again, that we're going to memorize, but being aware of. Okay. So if we talk about alcohol effects, right, on the brain, in general, right, it'll enhance the effects of inhibitory GABA, right? Remember we said GABA is an inhibitory neurotransmitter. So it will kind of think of it as if we think about inhibition of slowing down, right? Inhibiting neurons. And so it enhances GABA and it decreases the effects of glutamate. Glutamate is excitatory. So again, you get this overall sort of suppression, okay? It will also increase dopamine in that reward center that we talked about, okay? And so we can, again, think of alcohol as a sedative and a depressant. Why? It's increasing GABA, which is inhibitory. It's decreasing glutamate, which is excitatory, and that leads to an overall sort of sedative effect, okay? Also, does interrupt REM sleep. And so that's another sort of effect of alcohol, okay? Other kind of special things to think about, right, are the effects of alcohol on the developing fetus, right? There are fetal alcohol spectrum disorders. And again, there are, different sort of criteria and different types of these disorders. But, you know, children that were exposed to alcohol during the fetal stage will have various physical problems, also behavioral issues, and learning difficulties. And again, there's going to be a range in terms of severity. Okay. If you talk about early alcohol use, like in children, okay, impaired growth and development, increased risk for dependency, increased risk taking. Why? Your brain itself is still developing, right? So, until postnatally, there's a huge amount of time that your brain continues to develop postnatally, right after you're born. In fact, it goes on into teenage years. And so if you're then adding alcohol while you still have brain development going on, it's going to really have a lot of effects. Okay. And so some of them are listed here, but there are others as well. Okay. So now if you talk about different categories, so here's where I'm going to refer to a table that's in your book, and it's table 6.2. I think I have it listed, on the next slide. Okay, so there are different categories in terms of alcohol use disorder. We can talk about alcohol intoxication, alcohol overdose, and then alcohol withdrawal. Okay, and like I said, there's some more details in the table that I'm going to show you. So if we talk about alcohol intoxication, right, physical abnormalities, consistent with behavioral changes. I don't know, that's kind of like a weird sort of general statement, but we'll look at the table for some of these specifics. That's why I'm going to refer to the table. If you talk about overdose, well, now these impairments are going to increase the risk for harm, right? And then if we talk about withdrawal, there's going to be symptoms that will occur about 24 to 72 hours after cessation of drinking. Okay, so like I said, I'll show you the table that outlines some of these things. Okay, so these are some of the clinical manifestations that you're going to see in that table. But let me, like I said, I'll kind of show these, but then I'm going to also pull up that table because I think it has a little more detail. And so if we're talking about intoxication, right, some of the clinical manifestations you're going to see, right, increased risk taking, cognitive changes, ataxia, meaning you have this kind of you can't really walk straight, right? This problem with balance, nausea, vomiting. If you're now talking about overdose, coma, unconsciousness, right? Severe respiratory depression and can actually lead to death, right? Withdrawal. If we're talking about mild withdrawal, things like insomnia, irritability, headache, right? Nausea. Moderate, anxiety, right? Confusion, sweating. If you get to severe, uncontrollable shaking, agitation. Okay, so these are some of the clinical manifestations there. So let me, so sorry for the next slide that has a ton of words, but let me just show you what I was referring to. That is here. Okay, so this is this 6.2. So we listed some of the clinical manifestations, right? If you look at alcohol intoxication versus overdose, right? Versus withdrawal. This just gives you a little more detail, and then also adds in this column here that talks about linking pathophysiology to diagnosis and treatments, okay? And so I think that this is sort of important to look at this information here. Okay, so again, let me just kind of pause at each one so you can kind of see what's there in case you don't have access to the textbook. This is on page 128 if you do, but you can also just pause and look at it here. Okay, so now if we go to alcohol overdose, right? Remember, we have clinical manifestations in the center, and then linking, right, pathophysiology to diagnosis and treatment in that right-hand column. Okay, alcohol withdrawal syndrome, mild, moderate, and severe, like we talked about. Okay. All right. So let me go back to our PowerPoint here. Okay, so if we talk about heavy use, right? Alcohol use disorder, heavy use, what are the really serious effects that are going to occur after repeated heavy use, right? This is heavy use over time, over many years, okay? One thing listed here, the first one is chronic malnutrition and also effects on the liver, okay? So I kind of categorized it that way. So some of the reasons why you see this, right, is that alcohol is actually used as a fuel for the liver cells instead of fatty acids. And so what starts to happen is that the fatty acids get stored in the liver, right? And you kind of ever heard of like fatty liver and things like that. And so also because of that, there's destruction and inflammation of the liver because of this excess of fatty acid storage and the use of alcohol as fuel, because that's not really what these liver cells should be using. Also, cirrhosis can develop, right? So in cirrhosis, the liver cells are actually replaced with fibrous tissue. So it's not really liver tissue, it's fibrous tissue that really serves no liver function, okay? And so obviously that then impairs the function of the liver, okay? Also, chronic heavy use of alcohol leads to cancers. Liver cancer, right? But also lots of cancers of sort of the GI tract, mouth, tongue, pharynx, esophagus, stomach, pancreas, and there are more as well, okay? Can lead to hormonal changes. So in particular, there are studies that have shown that it can decrease testosterone levels and actually increase estrogen levels in males, okay? Which can lead to some physiological effects and even physical effects. Also, there have been brain imaging studies that show that there is brain tissue loss from alcohol toxicity or from repeated alcohol use, in that you can see that the amount of brain tissue is decreased, okay? Why? Because you are inhibiting communication between brain cells, right? By again interfering with neurotransmitter levels, okay? And if neurons or even glial cells, other brain cells, aren't able to communicate with each other or make connections, what starts to happen is those neurons can actually end up dying off, okay? So they need the connections with each other in order to survive. So it can ultimately lead to cell death, though the alcohol itself, I guess, the loss in brain tissue isn't due to alcohol, I guess, directly killing off the cells, okay? Something else here mentioned, organic brain syndrome, okay? So in organic brain syndrome, you just see this global decline in intellect, impaired problem solving, difficulty with fine motor skills, and actually organic brain syndrome is seen in this other syndrome. So Wernicke-Korsakoff syndrome, okay? And so in this syndrome, right, there's confusion, there's an ataxia, right, which is impaired balance or coordination. I mentioned that before, and memory deficits. And this syndrome is associated with deficiency of vitamin B1 or thiamine, okay? And in fact, also vitamin B1 deficiency will lead to peripheral neuropathy, right, where you have tingling and numbness in peripheral due to damage of the nerves. And it's believed to be due to impaired production of enzymes that are needed to maintain myelin. Okay, so the idea is, if we kind of think about, this sort of chronic malnutrition with alcohol syndrome, that this organic brain syndrome is likely due to vitamin deficiency. And it's similar to what we see here. So like I said, this syndrome is caused by a vitamin B1 deficiency. We see this same type of symptoms sometimes with repeated heavy use of alcohol, and most likely it's due to a deficiency of vitamin B1, okay, and other probably effects of the malnutrition that can happen with repeated alcohol use. Okay, in terms of diagnosis of alcohol use disorder, so there are some lab tests. So again, I'm going to refer you to a table 6.3, which isn't I don't believe I have it on here. No, it's not in the PowerPoint, but I'll show you that in a second again from the text. So there are different lab tests that you can do to basically kind of assess how serious this alcohol use disorder is. I mean, obviously you can measure blood alcohol, but usually we think about measuring blood alcohol levels as being a more acute kind of test. But some of these other tests, like bilirubin, has to do with function of the liver, right? So some of these other tests are related to more of the chronic effects of alcohol, some of the ones that we just talked about. Okay, so let me show you that. Let me just go to the last slide and then I'll show you that table. Okay, for treatment, obviously, the goal is to stop drinking, right? So there are behavioral treatments, there are also medications and other mutual support groups that can be used. And obviously this is a difficult thing, but as you saw in that 2 slides ago, repeated heavy use of alcohol has really, really dramatic effects on health. So let me again go back to that and show you that other table that I was just referring to. Uh-oh, hopefully it shows me. All right, so again, a reminder, look at these check your progress questions, right? These are in the book always. And so this is check your progress for 6.3, okay? We didn't talk about this a lot in terms of how does alcohol ingestion affect sleep, but we did mention it interrupts REM sleep, right? So, and this isn't really expecting you to give mechanism, okay? So we just want to know that it can affect REM sleep. Okay, so these are really helpful as well. A pregnant woman has heard from her friends that drinking alcohol in moderation is permissible during pregnancy. What patient education is important? Correct. It should be completely avoided. We really don't know what levels are safe. And so that's the reason why a clinician will tell you to completely avoid it. And so again, you don't know what levels are safe. And we know that repeated use of alcohol during pregnancy can lead to fetal alcohol syndrome. And so it should be avoided. Okay. In terms of medications, right, used for treatment of alcohol use disorder, I just mentioned that there are medications that can be prescribed, and these are some of them here. Okay. Again, do I expect you guys to memorize these medications or anything like that? No, but I think it's good to be aware, right? And so sometimes these might be used in combination with like cognitive behavioral therapy, but there are maybe we never really sort of think about medications as an option for treatment of alcohol use disorder, but there are some medications that are used. All right, so anyway, I just wanted to point this out to you guys. So it's good to look at these check your progress questions. All right, so this is what I wanted to show you. Again, this is showing you the lab test, right? The definition and what the normal values are. Okay, so here, this GGT, this is a liver enzyme. Okay, so it's increased by heavy alcohol intake. And again, we talked about the effects of alcohol on the liver. There are more we probably could have talked about as well. Okay, so again, take a look at this, explains what these lab tests are, right? And what they're related to, what the normal range is. Okay, again, another enzyme related to the liver, right? Told you again, this is related to liver function. Okay. All right. Okay, so I think those are important to look at. And again, if I'm going to ask you a question about these, I would provide you with some of this information, right? This could come out in a case study type question. All right, so I'm going to pause there, and then I'll put up another video where we start talking about tobacco use disorder, okay? Just because there's a lot of information here, so I'm just going to break it up. All right.